Hello everybody, my name is Olga Żmijewska-Kaczor. I'm the doctor in Royal Cornwall Hospital Trust Emergency Department and the ultrasound lead for emergency. And I would like to talk today about the echocardiography in life support. So why I think the core echocardiography is important? Well, because it will help you to make the right decisions when your patient is in cardiac arrest or deteriorating. And it's also easily applicable ultrasound technique that can be very quickly learned by the base level doctor. So ELS does not require complex measurements, but you have to remember that because it's so simple, its application is limited to cardiac arrest, deteriorating patients and peri-arrest settings. So when you think about the ELS during the cardiac arrest, it can only be performed during the 10 seconds window of pulse check. However, please don't be discouraged. Experienced emergency practitioner can gain adequate decision-making view in 94% of cases. So that's quite significant thing. And if you're thinking about the patient that deteriorates, that you're afraid that they will have a cardiac arrest, so peri-arrest decision-making, you can see if your patient have a pericardial or pleural effusion. You can assess their volemia status. So looking at the IVC, you can see if they're hypernormal or hypovolemic. You can assess the myocardial contractility. And also you can see if there is a right heart obstruction, including the PE. To gain the adequate view, you have to use the right probe. So for the isolated heart scanning, you should use the phase array transducer with a frequency that varies from 1 to 5 megahertz. It's called a cardiac probe. However, we can also assess the abdomen cardiac using it for the FAST and RUSH protocols, for obs and gynae examination, transcranial ultrasound, or lung itself. Now we will talk about the views we would like to acquire. So the first and the most basic views, and also the most used during the cardiac arrest settings, is a succiphoid view. So looking at the screen, you can see that the probe marker is on the patient left-hand side, and you're aiming to the succiphoid region. What you can see is the right ventriculum, tricuspid valve, right atrium, that's the septum, left ventriculum, mitral valve, and the left atrium. You can see similar presentation here. So we have a liver here. That's why we call this looking through the liver window. You can see the right heart, so right ventriculum, tricuspid valve, right atrium, that's the septum, and the left ventriculum, mitral valve, and the left atrium. So you have to remember that the closest to the liver is always the right heart, no matter what probe you use. In this case, I use the abdominal probe as the part of the EFAST protocol. The next view is parasternal long axis view, otherwise called PLAX, and I must say it's one of my favorites. So if you look at the transducer, so the North Shore indicator of the transducer is pointing towards the patient's right shoulder, and you have to position the probe about 2 centimeters next to the sternum in about 3rd or 4th intercostal space. The structures you can see in this view is aortic valve and the aortic root. You can assess the diameter and see if there is a dissection going on. You can see the right ventricular outflow tract. You can see the anteroseptum, left ventriculum. Just remember, we unlikely to see an apex of the heart. Now you have the mitral valve with both anterior and posterior leaflets, descending aorta, and left atrium. So on this scan, you can see the left ventricular outflow tract, left ventriculum, here, next the left atrium, and the aortic valve. You can see the nice clapping of the aortic valve. You can see the both leaflet of the mitral valve. So you can assess also the posterior border of the heart to make sure that you are not dealing with a tamponade. You can see the similar picture here. So again, right ventricular outflow tract, left ventriculum, both leaflet of the mitral valve and the aortic valve. Okay, so just remember, right ventricular outflow tract, left ventriculum, both leaflet of the mitral valve and aortic valve with the aortic root, and you can see here the descending aorta. Now it's one of my very first scans, and you can see again left atrium, left ventriculum, descending aorta, right ventricular outflow tract. The only difference is I placed the marker in the wrong position. So as you can see on the beginning, you still will make some mistakes, but if you can distinguish right from the left heart, it doesn't really matter at the end. You can still diagnose your patient. Now the parasternal short axis view, you keep your probe in a position the same as a long axis, so where do you find the heart, but you twist the transducer clockwise so the notch or the marker of the transducer is looking towards the patient's left shoulder. The structures you can identify is right ventriculum, septum. Now that whole left ventriculum, and you can see it's nice and concentric, when the right one is the lunar shaped, and you can identify the wall of anterior, inferior and lateral. Those little bumps that looks like two boxing chops, that's a papillary muscles. And again, you can see here on the scan, we have the septum, we have the lateral wall, inferior and anterior wall. Finally, apical or four-chamber view. You can see the transducer is in the anterior axillary line with a notch pointed towards the patient's spleen. So you start from the anterior axillary line, and then depends from the patient body habitus, you may move it centrally. The structures you can identify on this view is left ventriculum, mitral valve, left atrium, right ventriculum, tricuspid valve and the right atrium. And again, as you can see on the picture, that's the right heart. So you can see the right ventriculum, tricuspid valve, right atrium. On the other side, you can see the left heart. So you have left ventriculum, mitral valve and the left atrium. Here we have patient post-cardiac arrest. So you have to remember that post-cardiac arrest, usually we have a little bit larger right ventriculum. So you can see the right ventriculum, left ventriculum, tricuspid valve, mitral valve, left atrium and the right atrium. And you can see some floating bits in the right atrium. So if I see those floating bits before the cardiac arrest, I would strongly suspect the PE. However, post-cardiac arrest, sometimes you may have obstacles like that in the view. Now a little bit about the pathologies you can find. So first one of them will be the pericardial effusion. So the difference between the pericardial effusion and tamponade is strictly clinical. So if you see the pericardial effusion on the ultrasound scan, but the patient is not deteriorating, they are stable, it's unlikely or not possible that they have a tamponade. Because tamponade, as I said, is a clinical diagnosis. It's the impairment of the cardiac function that leads to the cardiac arrest or the cardiac shock. So here you can see the pericardial effusion. You can see the diastolic right ventriculum free wall movement. So it's like collapsing of the right ventriculum. You can see the effusion in the anterior and posterior aspect of the heart. And similar, you can see this on this picture. And again, you have the example of pericardial effusion. You can see beating heart and you can see the large rim of the effusion around it. It's not the best scan, but you can make a diagnosis if it's during the cardiac arrest. And again, we can see the example of pericardial effusion. So you can see the rim of effusion around the heart. You can see the right ventricular wall movement, so the collapsing of the right ventriculum. You can see the collapsing of the right atrium as well. So in this case, we're most likely dealing with a tamponade. So if you look at the screen, this patient possibly have a very poor blood pressure and is tachycardic. And again, you can see the rim of the effusion around the heart in a 4-chamber view. And if you look carefully, you can see the heart is twisting around the root. So it's something we call the dancing heart. Now, when it comes to the other heart pathologies, if we think about the PE, it's a little bit tricky because PE should be diagnosed before the cardiac arrest, and due to the fact that after the cardiac arrest or in the middle of the cardiac arrest, we always see some kind of right ventricular strain. However, if you have the deteriorating patient, what you have to look at is on the right ventriculum and the left ventriculum. So if the right ventriculum is dominant, and especially if during the systolic movement it's pushing the septum towards the left ventriculum, and in the same time, if you see stiff non-collapsible IVC, if you see the thrombus in one of the femoral veins, if you see the A lines in the lung ultrasound, it's very pathognomonic to the PE. Another pathognomonic sign is something called the McConnell sign. So you can see the hypokinesis or sometimes akinesis of the right ventricular wall with hyperkinesis of the apex. So you can see the apex is collapsing, like someone pushing the finger into it. And that's the sign of PE. So if you see something like that on a scan, right ventriculum dominant and Macaulay sign, you may diagnose your patient with PE. If they deteriorate, please start the thrombolysis straight away. Now we have a few peri-arrest cases. So on the first picture, you can see the pseudo-PEA. So this patient have the heart rate on a monitor, but there was no cardiac output at all. We thought it's a true PEA. However, when you put the ultrasound probe, you can see the heart is trying to contracting. However, it's not generating enough perfusion pressure, so the pulse is not palpable. In such a cases, I would advise to continue the resuscitation because this patient still have quite a good chance. On the other one, you can see the 4-chamber view, you can see the left ventriculum, and you can see the post-arrest heart that is trying to beat on the adrenaline drive. And at the end, a few bits and pieces about the IVC assessment. So remember, the IVC can give you information about the patient initial volume status. However, it won't be able to give you the information about the patient fluid responsiveness. So how you measure it? Well, you have to obtain the succiphoid view, then you twist the probe so the notch or the marker looks throughout the patient head. And then you see the IVC coming to the right heart, and measurement should be placed about 2 centimeters next to the entrance to the heart. In this point, you can measure the collapsibility of the IVC. If you have a difficulty to obtain the IVC, you can use the EFAST view, so right upper quadrant view, when you can see the IVC here above the aorta. And in this view, sometimes you can see the IVC is pulsing because the pulsation is the one that is shared with the aorta itself. That will be all about the core cardiac ultrasound. If you have any questions, please don't hesitate to find me on the shop floor and ask them directly. And I hope you enjoyed the lecture. Thank you so much.